Well, hello, my dear future doctors. Welcome to general and oral pathology tutorials. Hello, Philippe. Hello, Basil. I hope you're having a nice Saturday. Hello, Ali. Welcome.
Hello, doctor.
Uh, so I hope you're all doing well. I'm doing well as well because yesterday actually was a tough day. We there was the first case of confirmed corona in our hospital, and from yesterday on, we are now admitting corona patients as well because there are no places in the rest of the hospitals, and that's unfortunate outcome of this. Okay, so despite that I was allowed to bring my students, now it's quite dangerous for you to come there. So yeah, I guess it will be better. I hope it will get better. Okay. Yeah, but still, we don't have. We just have one case, so that's yeah. We are still performing surgeries.
Doctor, I want to ask a question before we start.
Yeah, please go ahead.
The, in the exam, it will be a cases or a definitions more?
Uh, the half of it will be definitions and half of it will be cases. Cases about the shock, I think. Okay, most of them will be about the shock cases, but the rest will be definitions because yeah, general
Thank
things. You're welcome. I'm fine. Yesterday was a tough Friday because my patient was tested for corona, and just this morning I got the answer, and so come continuously I was worried about because I had close contact. Obviously, I attended wounds, and we were in the surgery, so we were exposed to the virus as well. But she turned out negative, so quite relieved. But we have the other patient with corona, so still, yeah, there is a chance. We are being tested every day from now on. Yeah. Okay. Yeah. Enough with that. Bad news. Um. Enough. Let's join. Okay. I think I'm presenting now. Yeah. Yeah. All the hospitals are filled up, so my hospital has no other choice but to, yeah, there is no place to transfer those patients who need care, so there is nothing we can do about it, unfortunately. So before the rest of you join me, I will just in a few words review the previous lecture that was held on Thursday because of my request. And yeah, so we started discussing the chapter hemodynamic disorders, thromboembolic disease, and shock. This is the title of the whole chapter. But we've just discussed hyperemia, congestion, and edema due to different causes. Today we're going to talk about hemostasis and thrombosis, about hemorrhages, hematomas as well, and with a few words about DIC or disseminated intravascular coagulation. Okay, and that would be the pages 97 to 112, the short material, but quite interesting, in the basic pathology of Robbins. Okay, so I talked about the hemostasis. What is homeostasis? That's the general balance within the body. Hemostasis is the balance of hemodynamic balance, okay, between anticoagulative or procoagulative factors. There is a balance in between. Whether this balance is in favor of coagulative factors or anticoagulative operative practice, we've got the hemorrhage, or we've got the thrombosis. So those are the two different poles of the medal, okay? And first we started discussing the edema. Edema is the extravasation of the fluid from the tissues into the tissues, okay? It could be in not just in the soft tissues in the skin, but under the skin, in epidermis. It could be in the body cavities. So body cavities include a pleural cavity, and it will give a name of hydrothorax. In pericardial cavity, it will have the name of hydropericardium, and in peritoneum, yeah, you know that. Okay, so this is the hemostasis, what does mean, and thrombosis is the vice versa of it, okay? That could lead to myocardial infarction, pulmonary embolism, cerebrovascular accidents. That are the three most common causes of the death and disabilities in the population. Okay, and we discussed hyperemia, congestion. Both of them actually mean the increased volume of the blood within a tissue, but they have different causes and different pathogenesis development. Okay, so those hyperemia is actually due to active process, while congestion is the passive process. And hyperemia is due to dilation of our arteries and vessels, and that leads to increased blood flow. While the congestion is the disturbance and impairment of the venous outflow, okay? Outflow of the venous blood from the tissues. And the coloring is different. In hyperemia, we've got oxygenated blood, and that looks red. The tissues with hyperemic tissues look red because of that. And in congestion, we've got deoxygenated blood because of the impaired venous outflow, and they are like a blue-red color, cyanosis. So that's the difference, not just in the pathogen, but the outlook, the clinical appearance of it. Okay, so that's quite it. And here we see what the long-standing or chronic congestion might look like. And here we see the morphology. This is the alveolus, and here you see the small hemorrhages, congested capillaries within the alveolus. And this is the chronic one, the heart failure one, that is due to the chronic disease. And you see the hemosiderin cells that are heart failure cells, actually. Okay, and also the how to say, the shape of the alveoli is different within the chronic and acute process. You see, this is the integrity of the alveolar walls is messed up. Okay, so when we discussed the hepatic congestion as well, and morphology features of the hepatic congestion, acute and chronic as well. So this is the nutmeg liver. This looks like this and macroscopic feature, and this is the under the microscope, okay, microscopic picture, let's say. And you see that the central region of the hepatic levels are red brown and slightly depressed, and they're attenuated against the surrounding zones of unadjusted tan, and their fatty look gives the name of the nutmeg liver. Okay, so that's what congestion, hyperemia, and here we have the edema. So in different types of the tissue, how it looks like. Set the compartments, and then the body cellular matrix as well as the skeleton, and the whole body is made up mostly with the water, with the fluid and plasma majorly. So that's why extravasation leads to edema. Okay, edema in the cavities. sorry, yeah, that's not correct. That's just a sneeze. Okay, hydrothorax, hydropericardium, and hydroperitoneum. Okay, or ascites. Okay. That's we have discussed with the pictures, and I've said why this is dark, why this is light, and I will remind you. So dark shows the air bubble, so how air is easily passed by the X-ray. So that's why it's darkly stained, and the water cannot the X-ray cannot pass through the water or through the solid masses, just like bones in this case, ribs and the clavicle. So that's why this is the fluid. Fluid could be blood as well, right? But that's the difference of this. Yeah, that's what radiologists should know. Okay, so anasarca is the generalized edema, not just in the cavities and the particular zone, but the whole body tissues, and it looks mostly like this. Starts with the face. Okay, so yeah, that's a generalized edema, anasarca. Remember these terms, okay? And the mechanism of edema is usually what keeps fluid or blood streaming in the lumen of the vessels. These are two main types of pressure, hydrostatic and colloid osmotic. Any disturbance, any imbalance between those two leads to the extravasation of the fluid and development of the edema. And that's the general mechanism. Not just the difference between those two pressures, but also the lymphatic cleavage. If it's destroyed and if it's enabled, that is also the reason of the edema, because the lymph nodes, more specifically thoracic duct, is responsible to how to say to take down and to evacuate all the fluid that has escaped at the normal uninjured vessels, okay, during normal periods of time and healthy periods, okay. So this is the difference between transudate and exudate. We know that from the previous lectures. And so the resulting fluid could be either exudate or transudate, depending on the concentration of the proteins and cellular debris, okay? And that's the difference between the laboratory findings, okay? If you see those numbers, you know that less than 1.012 is the transudate, and more than that is exudate, because of, again, higher molecular mass, higher cellular debris concentration, and also our plasma proteins are a lot there. And these are the reasons and the pathologies where the when the edema develops, and which are the causes of it, okay, the mechanisms. No, yeah, I mentioned lymphatic obstruction. It could be post-irradiational, post-surgical, after the breast cancer removal of the breast, with the lymph nodes and lymph ducts as well, or post-radiation if they, yeah, destructed lymph nodes can no longer be responsible for the fluid, um, yeah, dissolution. Yeah, so that's quite it. And yeah, increased hydrostatic pressure might occur in the congestive heart failure during that. That might lead to generalized edema or anasarca, and the most frequent development is ascites in the peritoneal cavity. Okay, and portal hypertension is also responsible for the ascites. And this is the from your sorry from your book again. Yeah, I hope you've seen it. If you have not, just don't waste your time, go ahead and see it. And yeah, those two different causes. So hydrostatic was during congestive heart failure, for example. Osmotic during the malnutrition, if the patient is not taking enough proteins with food, or due to the loss of the proteins due to many conditions like renal insufficiencies and so on and so forth. And those all might lead to decreased osmotic colloid pressure that is mainly maintained by the plasma albumin. Plasma albumin that makes half of the masses of the proteins. Okay, we've got the rest of the proteins, but majority of it is the albumin. that makes up the total osmotic pressure. So that's also the cause of the edema. And here we have a bleeding edema, leaving a fingerprint because of the um, dissemination. Yeah. And lymphatic obstruction, I said that might cause the elephantiasis. Elephantiasis, this is the pathologic condition that might occur in the extremities or external genitals as well, due to lymphatic obstruction and parasitic, for example, parasitic infections like filariasis in this case. And this is iatrogenic after the removal of the breast cancer mastectomy. And with the radical mastectomy means not just the cancer or breast removal, but also lymph nodes as well, regional lymph nodes, maybe even further. So that leads to obstruction, lymph obstruction. Uh, yeah. And that was it, the clinical features of it. And I talked about brain edema because that's my favorite part, actually. And the brain, not like the rest of the organs, is the organ that is very delicate. Okay, cannot take even 1 centimeter shift, 1 millimeter difference makes a huge difference in the brain structure, and it's usually irreversible. So that's why brain edema is the one edema that needs a radical surgical approach, okay? Because the if swelling is due to tumor or due to abscess, it could be local, or due to ischemia, that could be total swelling, or due to trauma, it needs a radical surgical approach. Yeah, the compression surgeries that give the space of the or for the swollen brain to expand outside the skull, okay, under the skin. You can actually palpate the brain. Oh yeah. And preteen edema again. This is periorbital edema that is characteristic of the renal dysfunctions, usually nephrotic syndrome, and pulmonary edema. Very type, sorry. And brain edema. This is a gerunda tumor. This is the generalized one. So let me show you this one. So this is the subcutaneous. Resulting from the renal dysfunction is the periorbital edema, pulmonary, and the brain because of the trauma, for example. Okay. So that was the all with the previous lecture. Now let's start the new one. Okay, with the hemorrhage. So edema, actually the mechanism is the same. When the fluid escapes the vessels, it's called edema. But when the blood escapes the vessels, it's called hemorrhage. Okay. So a hemorrhage might occur during the injured. I hear something. Someone wants to talk, maybe. Ali, I think your mic is turned on. So
Yes, sorry, doctor. I wanted to ask you one question.
yeah.
Are we now reviewing everything, or we're going to have a new chapter?
No, I'm starting in a new chapter right now. Hemorrhage.
Okay, thank you.
Okay. So 15 minutes I give you for joining. I'm reviewing. I'm not wasting those 15 minutes, okay? So this is the hemorrhage, okay? So hemorrhage, as I told you, edema was the extravasation of the fluid. In this case, we got the extravasation of the blood. That's called hemorrhage. The extravasation of the blood from the vessels, most often the result of the damage to the blood vessels and defective clot formation. So it could be any injury, the trauma of the vessels itself, direct trauma, or it could be defective clot formation that leads to continuous bleeding or hemorrhage. Okay. So now This is the hemorrhage in the intestine, small chronic hemorrhages, and this is the hemorrhage in the brain, which is usually fatal, okay? In 80% of the cases. But this is the right lobe, I guess. That's not so fat and not so big. I will show you the really fatal intracerebral hemorrhages right later. So capillary bleeding can occur in the chronically congested tissues. For example, chronic heart failure or chronic pulmonary disease. They might cause small capillaries to rupture, and that could be a chronic capillary bleeding. Or during ulcers, small perfusion bleeding, okay? Trauma, atherosclerosis, and inflammatory or neoplastic erosions of the vessel wall also may lead to the hemorrhages, which may be extensive if the affected vessel is a large vein or the artery. Obviously, hemorrhages differ uh, according to the size of the vessel. It could be arteries, veins, and capillaries, and the caliber of those vessels, okay, the diameter. If there is a huge bleeding from aorta, for example, it's lethal. If not detected early and if this without the surgical intervention, it's a fatal one, okay, 100% lethality. And the risk of hemorrhage is increased in a variety of clinical wide variety of clinical disorders. They are called collectively hemorrhagic diathesis. Okay, diathesis. So this is the picture of it. And diverse causes are usually because of the including inherited ones, acquired defects in the vessel walls, for example, brain aneurysms. Okay, this is the weak part of the vessel that bubbles up. Okay, like a balloon, and this is the weak part. And if the high pressure during the high pressure, it usually ruptures and causes intracerebral hemorrhages or subarachnoid hemorrhages and so on and so forth. And also coagulation factors mostly contribute to the development of hemorrhage because of the how to say not rapid termination of the bleeding. All of these all of these, I mean, blood vessel walls should be intact, endothelium should be intact, and also coagulation factor should be in order for the hemostasis. Hemostasis of this is the normal stage when the pro and anticoagulant factor are at same balance. Okay, at same level. Hemorrhages may be manifested by the different appearances and the clinical consequences. Okay, and you see here hemoperitoneum. The picture looks much like the hydrothorax, okay, but the fluid is different. Fluid is blood in this case, okay. The external or the bleeding could be external if we've got injured skin or injured surfaces, but it could be internal when, for example, during internal trauma, abdominal trauma, when we have the ruptured spleen, it's what we call spleen arteries, it's internal bleeding, and that could lead to formation of the hematoma. Hematoma is a huge blood clot where you can imagine when the blood bleeding occurs internally, the coagulation factors work there, and these blood clots, and the huge blood clot is hematoma, literally. So hemorrhages they vary from the trivial to the lethal. Trivial could be just the bruises when you hit your hand or head, but it could be fatal in case like massive retroperitoneal hematoma that is a resultant of this dissecting aortic aneurysm, for example, or rupture of the aorta during the trauma. Okay, and the large bleeds into body cavities are described variously according to the location, as the fluid during edema. So, but the suffix is different in this case, not hydro, but hemo. Hemothorax in the case of the pleural cavity, hemopericardium in the case of the pericardial bleeding, hemoperitoneum, or in the case of the abdominal bleeding, and hemarthrosis, it is in case of the when we have the blood accumulation in the joints. Okay, hemarthrosis. And the jaundice is a quite a common clinical feature of the bleeding. Jaundice from the massive breakdown of the red blood cells, and the hemoglobin is the clinical feature of the massive blood loss as well. And this is high hemothorax, and this is hemopericardium. This is hemoperitoneum. As you see, this is the contusion, hemorrhage. This is vertebral column, liver, and this is hemoperitoneum, active bleeding. Subcapsular hematoma. This is the kidneys. Okay. And artery, the hemarthrosis in the knee joint. You see this postoperative scar, and there is a bleeding, which looks like the patella is deviated because of the blood accumulation in the joint. Okay. And here we have 3 different types of the hematomas, the small ones. Petechia, this is the minute 1-2 millimeter diameter hemorrhage in the skin and the mucous membranes and serosal cavities. We've got purpuras, and we've got eschimosis as well. Okay, so I will discuss each of them one by one. And this is the petechia, this is the purpura, and this is the ecchymosis bruces, which we call them. Okay, and this is all 3 of them together. And one by one. So petechia, it's a minute 1-2 millimeter diameter hemorrhage into the skin. It could be in the mucous membranes of the mouth, for example, of the eyes as well, and a serous surfaces. It causes include low platelet count, coagulation factors, thrombocytopenias, for example, and defective platelet functioning, as well loss of vascular wall support and deficiency of the vitamin C, for example, that leads to the loss of vascular wall support as well. Purpura, as you can see in this picture, this is slightly larger than petechias. There's 3-5 millimeter hemorrhages, result from the same disorders as the petechias, but plus we've got vascular inflammation like vasculitis and increased vascular fragility. Okay, usually present in the lower extremities. And finally, eschimosis, those are the bruises, and here you see the different aging of the bruises. Okay, so they are larger, 1-2 centimeters, and subcutaneous hematomas are usually collectively called bruises. Extravasated red cells are phagocytized and degraded by the macrophages. That gives a different colored appearance to the ecchymosis. Color changes of the bruises result from the enzymatic conversion of the hemoglobin. It could be red to blue at the beginning, and to the bilirubin if we've got an blue to green color, and lastly hemosiderin, which is golden brown color, and that's the resorption of the bruises. Okay, and here we see so clinical significance depends on the size of the vessel that is injured, as well on the loss, the amount of the blood, and how fast is it lost. That means the rate of the blood loss. Okay, so depends the clinical significance depends on the volume of the blood that is lost and the rate of the bleeding. Rapid loss of the 20% of the blood volume, or slow losses even of the larger amounts, have little impact on the healthy adults usually. But the greater losses can cause hemorrhagic shock, which is the kind of hypovolemic due to the loss of blood volume. Hypovolemic shock. Okay, that could be lethal without the proper intervention. And this is the lethal intracerebral hematoma, as I said. This is the left hemisphere. This is right. This is left. This is the huge, almost the whole hemisphere is the intracerebral hematoma. And you see the shift of the medial structure. So this line should be like this, but this is the shift. So left ventricle and right ventricle. Left ventricle is almost undetectable because of the compression. This is the lethal. This will lethal in a few days if we don't do decompression and evacuation of this hematoma to give the brain to room to swell. This will definitely swell because a small change in the brain leads the reaction that is edema. Okay, swelling of the brain. Right. Trivial could be in case of the subcutaneous tissues, but deathly could be in case of the brain hemorrhage, hematomas, chronic or recurrent external bleedings, for example, due to peptic ulcer, that leads to opening up the wound and bleeding, and the menstrual cycles, for example. And this chronic and recurrent external blood loss usually lead to iron deficiencies, anemias, okay, because of the continuous loss of blood and iron. And iron efficiently recycled from phagocytized red cells. So internal bleedings during traumas do not usually cause iron deficiency, but the chronic ones, extended and continuous ones, usually cause iron deficiencies. And that's the defines the treatment includes as well. So hemostasis and thrombosis, the next thing. As I said in the beginning, those are two sides of the one medallion, okay? So hemostasis means the keeping the blood into the bloodstream and not letting go, not bleeding, okay? Formation of the blood clot to prevent the bleeding. But thrombosis is a formation of the blood clot, but in case of the intact endothelium, okay, in uninjured states. In the normal states where we don't need the formation of the clot, that leads to thrombosis, clotting of the vessels, and disturbing the normal blood flow, okay? So let's start with hemostasis. So this is the precisely orchestrated process involving platelets, involving clotting factors, and finally endothelium that occurs at the size of the vascular injury and culminates in the formation of the blood clot, which prevents the bleeding. So that's the definition of the hemostasis. We've got four stages or the steps of the hemostasis. First is arterial vasoconstriction. The second in the primary hemostasis of formation of the primary clot, platelet plug. Then is the secondary hemostasis that leads to deposition of the fibrin and formation of much restricted and cementified clots. And lastly, clot resorption or stabilization, okay, after the stopping the bleeding. So let's discuss one by one those steps. The first was arterial vasoconstriction. As you see, when in normal endothelium, we've got the other factors like nitric oxide, like the factors that keep the vessel dilated and keep the thrombocytes from adhering each other and forming the clots in the normal state. But when we have the injury of the endothelium, we've got the arterial vasoconstriction or constriction, narrowing the lumen of the vessels in order. This is the protective mechanism to stop the bleeding. First mechanism. It occurs usually immediately and reduces the blood flow to the injured area. That reduces the blood loss as well, right? And it's mediated by the reflex neurogenic mechanism and augmented by the local secretion of the factors such as endothelin, which is normally not secreted in the healthy, intact endothelium, but only when we have the injury of endothelium. And this is the potent endothelium-derived vasoconstrictor, and itself promptly promotes the constriction of the vessels. Okay, so effect is the transient, so it means it passes. It's not permanent one, and the bleeding would resume if not for the activation of the platelets and the coagulation factors. So vasoconstriction is just for a few seconds, few minutes. You can apply it, but it will resolve finally, and the bleeding will resume if we don't have the second phase of the hemostasis, which is the primary hemostasis, actually, the formation of the platelet block. So the disruption of the endothelium exposes subendothelial factors, which is von Willebrand's factor, WF, and the collagen of the injured endothelium. This all promotes the platelet adherence and activation. And you see those platelets that change the shape and adhere to the injured side. And here we see for Willebrand factor, here we see other mediators of coagulation factors as well. So the shape changes from the small rounded discs to the flat plates with the spiky protrusions, as you see on this GIF, that markedly increases the surface area surface coverage of the injury, okay, as well as the release of the secretory, as you see, the release of the secretory granules, which are illustrated on this picture as well. So secreted products recruit additional platelets. Those secreted factors attract the platelets, their platelets, which undergo aggregation to form the primary hemostatic plaque. And this is the formation of the primary hemostatic plaque. So this plaque is not so strong to hold the bleeding totally. So we need the third step, which is the secondary hemostasis or deposition of the fibrin. Okay, so the tissue factor binds and activates factor 7, setting in motion a cascade of reactions that culminates in the thrombin generation. Okay, thrombin, as you can see here, is the one that makes more solid the connection between those platelets, cementifying them and making the secondary clot that is a lot more stable than the first primary one. Okay, so thrombin cleaves circulated fibrinogen into insoluble fibrin, creating a fibrin meshwork, and also is a potent activator of the platelets, leading to additional platelet activation and aggregation at the site of the. Sorry guys, I haven't slept last night. I'm waiting in fear. Okay. Tissue factor, as you see, here we have the thrombin that activates fibrinogen into the fibrin, and fibrin makes the meshwork that is a lot more stable than the primary clot and consolidates the initial platelet plaque. That's the third thing. And lastly, the outcome, the final step, is the clot stabilization and the resorption when there is no need of the clot anymore. So polymerized fibrin and the platelet aggregates undergo contraction to form a solid, permanent plug that prevents the further hemorrhage. Okay, and the counter-regulatory mechanism, for example, tissue plasma manager activator or TCPA, as we know this. They are set into motion that limit clotting to the site of injury and eventually lead to the clot resorption and the tissue repair. Okay. This is the last and fourth and last step of the hemostasis. So it should be emphasized that endothelial cells are central regulators of hemostasis. As I said, the balance is either on the side of pro-coagulative factors or anticoagulative factors. So the balance between the antithrombic and prothrombotic activities of the endothelium determines whether thrombus formation, propagation, or dissolution might occur. And normal endothelial cells express a variety of the anticoagulant factors and vasodilatory factors that inhibit platelet aggregation and coagulation and promote fibrinolysis, so breaking down the clot when it is not necessary. Okay. And platelets. So as I said, those as the leukocytes were the major players in the inflammation and the thrombosis, blood clotting, and coagulation, we've got the platelets. Platelets that have a crucial role in coagulation. They play a critical role in hemostasis by forming the primary plug that initially seals the vessel defects and by providing a surface that binds and concentrates the activated coagulation factors. Okay. So those platelets, as I said, they change shape according to the stage of the hemostasis, and they produce the coagulatory factors that attract more of the platelets and lead to more strong connection between those two. And it looks like the meshwork, really. So disc-shaped and nucleate cells, fragments that are shed from the megakaryocytes in the bone marrow into the bloodstream. We've got two types of granules, alpha and beta granules. Alpha granules adhesion molecules like P-selectin of their membranes and contain proteins involved in a coagulation like fibrinogen, coagulation factor 5, von Willebrand, and so on and so forth. And we've got not the beta, but delta.
Doctor,
Usually,
if interrupting,
yeah.
should we memorize this information about alpha granules and
As much as
no?
you can. Maybe not all of
Okay,
this, but yeah, as much as you
okay.
can. Yeah. And dense delta granules that contain adenosine default ADP, and they again you don't need to memorize this. Adenosine triphosphatide is a calcium and so on and so forth. Just the two granules, two types of granules, and in which phases they are active. Okay. So, what is blood coagulation cascade? So, as I said in the beginning, in a normal, healthy, uninjured endothelium, we've got the factors that keep the blood vessels dilated at normal shape and prevent the platelets from attaching to each other and forming the clot. So, those factors include nitric oxide that is a vasodilator and prostaglandins that keep platelets separated from each other, with prevent them from bumping to each other and at teasing. Okay, but when we have the injury, and when we have the first thing, the first reaction is vasoconstriction because of the decreased nitric oxide concentration. We go to vasoconstriction, the narrowing of the lumen, and we've got the production of the platelet activation factor, ADP, thrombin, thromboxane, serotonin, all these that attract the platelets to the injury site and start the platelet activation, okay? And formation of the primary clot, and after that, the secondary clot, and so on and so forth, okay? So that's the picture. And here we have the first thing that happens is platelet adhesion. Okay, when the thulium is injured, platelets adhere to it and virtually cover the exposed collagen of the surviving thulium. So that's the first reaction of the platelet. They cover the surface in order to prevent the further bleeding. Okay. The second, so the platelets rapidly change their shapes. As I said, from the disc shape, they have like spiked protrusions, and they cover more surface area like that. And the third thing is the platelet activation. Actually, the main thing is the platelet activation. So secretion of or release reactions, so it's called release of the granule contents, including ADP, thromboxane, serotonin, platelet activated factors, and thrombin. That in their case, they also attract the other platelets and start the formation of the clot. And platelet aggregation. So platelet activation leads to platelet aggregation, collection of the platelets. Increase in cytosolic calcium levels leads to the release of platelet granules that contain ADP and serotonin and the other mediator, the other factors, and it leads to an activation of the thromboxane synthesis, activation of the glycoprotein 2B3A. This is really important. Remember, this is 2B3A that bind to fibrinogen and regulate the platelet interaction, okay, making fibrin a meshwork. And thrombus formation, that is a reversible platelet contraction, okay. And every step, if we have a deficiency that leads to the how to say, the pathologies. For example, if we have deficiency of the von Willebrand factor, coagulative cascade would not form in this way, and we'll have the von Willebrand disease. If we have the deficiency of the glycoprotein 1b, for example, we have the Bernard-Soulier syndrome. And if we have the deficiencies of this glycoprotein 2b3a, this leads to deficiency of the Glanzmann's thrombostenias. Okay, this is what you should remember, Ali. And then, so fibrinogen, this is the soluble plasma glycoprotein, simultaneously binds to the glycoprotein 2b3a, and results in the cross-linking of the platelets and platelet aggregation, forming a much more stable clot than in the primary hemostatic plug. Okay, that would be the secondary one. And the formation of the clot. So this is the local stimuli of the coagulation cascade by tissue factors that results in the formation of the thrombin. Thrombin is a coagulator factor 2A. Why A? A means activated, okay? Without A, they are not activated. So factor 2A is the thrombin. And thrombin, this is the serine protease that catalyzes the hydrolysis of the fibrinogen to fibrin that leads to cross-linking of the fibrin threads and stabilizes the clot that forms more stable secondary clot, hemostatic platelet fibrin plaque. Okay, and that is all with the hemostasis, and that's the summary. I will quickly read this one. Endothelial injury exposes the underlying basement membrane extracellular matrix. Okay, platelets adhere to the extracellular matrix, and primarily through the binding of the platelet glycoprotein 1b, that receptors to the von Willebrand factor. Okay, or the deficiency of those two, we know what types of disease they cause. Okay, adhesion leads to platelet activation, an event associated with the secretion of the platelet granule contents, including calcium and ADP. And then glycoprotein 2b3a receptors activate platelets by forming crosslinks with fibrinogen, leading to the platelet aggregation. And we have the more secondary hemostatic plaque formed because of the fibrin and thrombin all together. Okay. that was it. So before the coagulation cascade, I will give you the break. Okay. I will be back in 10 minutes, okay? Meanwhile, you read the
Okay,
summary.
doctor.
Mhm. Okay, guys, let's continue. We have not much left, so let's get on well quickly because we have elections today in our country. So the coagulation cascade, as in your book, is described as a dance with multiple participants, and participants are called the factors, coagulatory factors. Okay, this is the series of amplifying enzymatic reactions that lead to the deposition of an insoluble fibrin clot. Okay, so the dependency of the clot formation on the various factors differs in a laboratory test tube and in a blood vessels in vivo. In vitro, it means in tubes. In vivo means in life, in real living material. Okay, so this is how the clotting in laboratory happens. This is how it happens in vivo. You see the factors that push each other like domino effect, and a final stage, as you can see here, is the same formation of a fibrin clot. Okay, thrombin, fibrinogen, and fibrin. This is the part where they come together and combine, and this is how they differ. Okay, activation of those two factors. And this we differ two pathways, eccentric pathways and eccentric pathways of coagulation. And eccentric pathway starts with the activation of the factor 12, and then we've got 11, 9, 10. Then finally prothrombin activates the thrombin that makes the fibrinogen transformation into the fibrin and formation of the fibrin clot. This is the eccentric pathway. Now eccentric, the pathway that starts with the factor 7 activation. A means activation, and from then on it's the same, like 10 thrombin, fibrinogen, fibrin, and finally a clot. So this is the part where the eccentric and eccentric pathways cross the paths. Okay, so here we see also the other illustration. This comes from your book. So this is the inactive substrate or inactive factor without the letter A. This is active one, then activation of the 10, activation of the 2. That is the cascade. That's why it's called the cascade. Okay. So, and we have two types of assays to confirm the coagulatory deficits and pathologies. The first one is prothrombin time. Okay, to assess this time, and if it's prolonged, it means we have the deficit of the prothrombin. So it assesses the function of the proteins in the eccentric pathway, including 7, 10, 5, 2, which is prothrombin, and fibrinogen. And tissue factor, phospholipids, calcium are added in the tube, as you can see, and the time for the fibrin clot is recorded. If it exceeds the proper time, it means we have the deficiency of this listed factors, and this is called prothrombin time. But we have PTT as well. PTT test is a partial thromboplastin time, which screens the function of the proteins in the eccentric pathway, including 12, 11, 9, 11, 9, 8, 10, 5, 2, and lastly fibrinogen in both PT and PTT. And the clotting of the plasma is initiated by the addition of the negatively charged particles, for example, ground glass, and then goes the same like in the PT test. Okay, and finally noting recording the time of the clot formation. So, and the thrombin. So we said that this is the really important factor that leads to the conversion of the fibrinogen to the fibrin that cross-links the platelets together and makes a strong meshwork and strong secondary hemostatic clot. That's the with thanks to the thrombin. Then it also stimulates the platelet aggregation and activation, and it's a pro-inflammatory effect because of the prostaglandin prostaglandin, how to say, secretion or stimulation, and anticoagulant effects. It's illogical, but still, thrombin in the normal uninjured endothelium, in intact endothelium, has anticoagulative effects as well. So you see the variety of the functions of the thrombin that is discussed in one. That is described in the one illustration. You see that it causes endothelial activation, lymphocyte activation during the inflammation, also monocyte activation, prostaglandin release, smooth muscle contraction. This is extracellular metric, the injury, thromboxane release, fibrin conversion, and platelet aggregation, as well as neutrophil adhesion during the inflammation. Okay, that's all. Now, so factors that limit the coagulation. That means they cease the coagulation. These are called fibrinolytic cascade, not coagulative cascade, but fibrinolytic. Lysis means the breaking down the fibrin clot. Okay, this limits the size of the clot and contributes to its later dissolution. And plasmin is the one that is responsible for the breakdown the fibrin and interferes with the coagulatory cascade. Okay, so this is thrombin, the tissue plasminogen activator, fibrin clot here we have, and the free plasmin that degrades the fibrin clot, okay, breaks it down and leads to resorption, resolution of the thrombus, okay. And dead dimer, this is the product of the fibrinolysis, and the product of the fibrinolysis gives us the idea during some pathologies at which point the organism is, okay. Elevated level of the breakdown products of the fibrinogen, often called fibrin split products, gives them idea that we have the thrombosis somewhere. We have, for example, during myocardial infarction, if we find the day dimers, or mostly during pulmonary embolism or pulmonary artery thromboemboli, we measure the dimer. It shows the level of hypercoagulation, and we suspect the embolism, then thromboemboli, and we do the further diagnostic tests like CT of the thoracic segment and so on. Okay, and so this is the most notable fibrin-derived dimer. It's useful clinical marker of the several thrombotic states. And about thrombotic states, we're going to talk. Yeah, that's the thrombosis of the arteries, the clot that is stuck within the vessel lumen and blocks the normal passage of the blood. The blood flow is blocked with the thrombus. The primary abnormalities that lead to intravascular thrombosis include endothelial injury first. The second will be stasis of the turbulent blood flow because of the thrombus. So because of the injury, we've got the thrombus formation. But because of the thrombus formation, we've got disturbed turbulent blood flow. And lastly, hypercoagulation of the blood. So this is the state, hypercoagulability, that leads to turn the metal on the other side and leads to thrombosis, okay? Doesn't prevent any longer the bleeding. Bleeding has stopped, but thrombosis goes on, and it blocks the blood flow, and it blocks the supplying tissues with the blood and with the nutrients, and causes ischemia, okay? Ischemic pathology. So here we have the Virchow's triad, that is the famous one. Thrombosis. Thrombosis that is due to endothelial injury, due to hypercoagulation, abnormal blood flow, and yeah, they are interconnected with each other. Okay, Virchow's triad. And yeah, this is the factors that inhibit thrombosis, okay, like heparin-like tissue factor inhibitors, thrombomodulin, those that inhibit thrombosis, but those who promote the thrombosis, for example, injury and coagulator factors like von Willebrand factors and exposure of the collagen fibers, those all lead to the thrombus formation. Okay. And endothelial injury, we'll discuss that's quite clear. There is no need to discuss it any longer. But let's talk about abnormal blood flow and hypercoagulability. Okay, so this turbulence, this is the chaotic blood flow, contributes to arterial and cardiac thrombosis by the causing endothelial injury or and dysfunction, as well as by forming countercurrents and local pockets of the stasis. Okay, so disturbance of the blood flow or the stasis leads to further aggregation of the platelets and further formation of the clots. While hypercoagulability, increased coagulation, it's abnormal high tendency of the blood to clot, and is typically caused by alterations in the coagulation factors. They increase and decrease an imbalance between those factors that are procoagulant and anticoagulant. Okay, so this is the primary hypercoagulation that leads to the deficiencies of the proteins and these factors. And here we have the secondary or acquired hypercoagulation, for example, those who have risk of thrombosis, prolonged bed rest, ambulation, myocardial infarction, atrial fibrillation. Remember, atrial fibrillation, the patients with atrial fibrillation are at high risk of thrombosis, thromboembolism. Okay, that's why anticoagulant should be used. And prolonged bed rest, for example, trauma or patients, neurologic patients who disabled with hemiplegias or paraplegias, or those who need immobilization due to traumas, for example, fractures, and they've got knee replacement or femoral joint replacement surgery that lead to the lying state or bed rest. Those patients are at high risk of the thrombosis, so that's why low molecular anticoagulant should be given to them. Okay, cancer and the DIC also increases the risk of thrombosis. You don't have to remember all this list, just pass through it. Okay, but with the reading, without reading, don't pass through it. Okay. So then here we have the condition like heparin-induced thrombocytopenia. Okay, heparin is given to the patients in order to, for example, in bed rest regime patient to avoid the hypercoagulation, but it might induce thrombocytopenia. So heat syndrome is quite common with the long-term heparin usage. It occurs in up to 5% of patients treated with unfractioned heparin. That is anticoagulant, obviously. And the new generation of the anticoagulants, like Xarelto, that is frequently used after the heart prostate heart wall replacement or after stenting the coronary arteries or after coronary shunts. Those new modern anticoagulants are usually less likely to cause the heparin-induced thrombocytopenia or heat syndrome. Okay, so the mechanism of this is quite unclear how it causes thrombocytopenia, but the fact remains a fact. Okay, antibodies also bind to the complexes present on the platelet and endothelial surfaces, resulting in the platelet activation, aggregation, and consumption, causing endothelial cell injury. So prothrombotic state, even in the face of the heparin administration and low platelet count. And the other syndrome, very interesting, rare and not so common, but usually with a bad outcome. It's antiphospholipid antibody syndrome. That is a second name, an older one is lupus anticoagulant syndrome. You know, lupus erythematosus, but it's different. That is causes recurrent thrombosis, repeated miscarriages and abortions, and cardiac wall vegetation, as well as the thrombocytopenias. Okay, those features are common with antiphospholipid antibody syndrome. It's quite difficult to diagnose, but we still do. The clinical presentations include pulmonary embolies following lower extremity, deep vein thrombosis, pulmonary hypertension from the recurrence of clinical pulmonary emboli, and stroke and bowel infarction. That's why these patients also appear to be ours as well, and renal vascular hypertension, which is a resistant hypertension and really difficult to treat. Okay, and lastly, with a few words about the disseminated intravascular coagulation, DIC. This is the widespread thrombosis within the microcirculation that may be of a sudden or a serious onset, very prompt start, and usually in 99.9 cases the lethal outcome. Okay, it consumes platelets and coagulation proteins, and the other name is called consumptive coagulopathy. So at the beginning it starts as the protective factor or protection from the blood loss, but then using up all the coagulator factors at the same time fibrinolytic mechanisms are activated, and excessive clotting and bleeding at the coexist in the same patient that leads to fatal outcome usually. Okay, and unfortunately. So this summary. So let's summarize thrombosis, and today's lecture was quite short, but that's it. So the thrombus develops is usually related to one or more components of the Wehrhaus triad, which was endothelial injury, turbulence disturbance of blood flow disturbance, and hypercoagulation. And then endothelial injury, is by the toxins, hypertension, inflammation, metabolic products, while abnormal blood flow studies or turbulence is resulting from the aneurysm, for example, or atherosclerotic plaque, and hypercoagulation due to primary could be deficiency of the factors, genetic, or is acquired, or could be secondary during the bed rest, damage, and malignancies and cancers and the others. So thrombi might propagate. So what are the outcomes of the thrombi? Thrombi might propagate, might resolve, might be organized, or embolize. And the embolism or detachment of the blood clot or thrombus and migrating clots that are called embolus, we're going to discuss in the next lecture. So thrombosis causes tissue injury with local vascular occlusion or by distal embolization. Okay, that's quite it with today's lecture. And my request for you is to use your brain, because neurons don't need social distances, unlike us. Okay. Okay, thank you very much for your attendance, for your attention.
Doctor,
Yeah,
can you
that
send
was a
us the PowerPoint
yes, yes,
after
yes.
this lecture?
I have together, so I'm gonna send you this presentation.
Okay, thank you, Doctor.
Bye bye, thank you. Have a nice
Bye.
weekend and a week ahead.
Thank you.
Bye.